Hey, how's it going, everyone? Welcome back to another MRAP Grand Rounds. I'm Scott Kovner, joined by
Whitney Johnson, Saturday Night Live.
Saturday Night Live.
I meant Grand Rounds.
On a Tuesday night.
All right.
Welcome to 2023. How's your year kicked off so far?
So far, it's great.
Just a whole bunch of shifts, you know,
that's it.
the typical.
Great.
Yeah.
Changes to all of my EMR systems and the zombie apocalypse.
You're already stressing me out what we're going to talk about tonight. Thank you guys for joining us. We're super excited. Obviously, we've been doing these every month. This is our EM1. Next month, we're going to hook up with some urgent care. We alternate every month. If it's your first time joining us for one of our Grand Rounds, you know, in the doobly-doo down below, slam that subscribe button, hit the little notification bell, whatever, so you know whenever we're posting. You can come on board, ask some questions.
The doobly-doo?
The doobly-doo. That's
the bodily bip?
The doobly-doo? Exactly. That's what that's a technical term.
So.
You know, we'll get into it later. So let's jump off with the students. So who do we have tonight? Who's joining us tonight?
So we've got a bang-up group of faculty today. We've got the one and only Dr. Sara Crager for all things super sick and critical care. We've got the super great Sean Nort with more degrees and fellowships than I can count, but for all things farm, that's Dr. Nort for you.
They've been talking to the American boards, like certification group, to create more boards for him.
They cut him off.
Yeah,
like, it's done. It's over. And joining us in spirit, giving us a hoorah, Dr. Mel Herbert. Shout out to him.
He'll be in the chat, probably. Yeah, don't fire us. Probably answering a bunch of questions, having some fun there. Maybe come by at some point. We'll see.
To fire you.
Yeah, so wonderful. Just a reminder, so we're going to be using Slido tonight. This is like our little polling software for our games, for some Q&A stuff. You can join at any time before each segment that we use it. We're going to put up this screen. You can, if you have another device with you, you can just join in right now, and you'll get the polls fed to you as we go. Easy way to keep track of everybody. And for any of the quiz stuff that comes up, put your name in so that when you win something, you know, we know who to send it to. We don't have to track you down. It's not hard to track you down for that. So that'll be pretty fun. And of course, we'll start tonight with some headlines and bottom lines, some stuff that's happened in the news, some medically relevant, important things. Ready to jump into it?
Let's do it.
All right. So the first thing you alluded to, new coding guidelines for emergency medicine.
With this?
You know, it's the thing I'm most excited about. You know me. I love documentation and then also completing charts on time. Those are my two passions in medicine. So. Have you had some experience with new coding yet? Have you had a lot of shifts?
Where's that like emoji with the angry face and the bleed? That is how I feel about this. But yes, as of January 1st, you know, the billing system, it went from it being about like how many ROSs you've got and how many elements you have in your HPI to now they're leaning towards just the MDM being the predominant thing that they're using for billing. And there's a lot of elements that they put in there. My 10-minute note now takes me 25 days. So,
and you know, we had a breaking news done by Jess Mason that came out on the podcast to cover some of these things, some of these changes, some of these updates, so we know what we're supposed to be doing. And then also the Compendium chapter got updated in record time to have all the hot tips, what you need to know, how the notes are scored. It's a lot of big changes. I mean, like for what, 20 years, it's been that system, like you said, of points in the HPI, review of systems, and now it's all in the MDM. I agree. My hot take is that the notes that I'm writing are taking a little bit longer because I'm unfamiliar with it. I want to make sure I got all the stuff in there that I need. I think that'll get better over time.
Hopefully. I mean, I think it's the same as when we started, like with the Epic templates and your Dragon templates. I'm a little crotchety because I have like my Dragon templates and I'm so fast with them. So now I have to like do some finagling to that. So it's a little bit of a pain point for me, but I will survive.
I think the overall goal was really great in that we're going to get more credit for thinking, right? So the descriptions of stuff that you have in the MDM, like tests you might have ordered while you didn't order a test, therapies you considered providing, all give you points for complexity of care. I think the thing that I've personally found with the environments that I've worked in, my own notes, is like, you know, we're trying to reduce note bloat, you know, the things that we're just including in there for not really any benefit to the patient, benefit to other clinicians, but for billing. And I always found like the MDM was the one safe haven in the way we used to have our notes, where it was like a chance for us doctors to like talk to each other about what's actually going on. So trying to structure your note with these new guidelines to preserve that, I think, is like the most important thing. And the thing I found most frustrating when now it's like a template and I don't actually know what happened to the patient. So
it'll be interesting to see how it pans out, right? Because I could also see like from the medical legal standpoint, a little dicey when you say something like, I considered this test but didn't do it. So I think that we have to kind of find that standardized approach to this, and I know it's coming down the pipeline as we all start to figure it out. But, you know, track Compendium because it's updated live, so
yeah,
probably
we'll grow and learn, and hopefully it'll be a lot better for everybody, including patients. Most important people in the whole process, right? Now onto a new headline, a new segment. is this a new cryptocurrency or a new COVID variant? I feel like the names of these are so interchangeable. So XBB 0.1.5.
I need money.
You need money. Yeah, unfortunately, this is a novel variant. It's not a new cryptocurrency for us to waste our money on. We thought we'd give a quick little COVID update. This is the CDC's COVID-19 tracker, updated weekly, part of their Nowcast. And you can see this new variant, XBB 0.1.5, is quickly becoming or going to become the most common observed variant in the United States, which is a little bit of the bad news. The good news is it doesn't seem to be worse than other variants. The vaccine seems to be decently effective. We don't see increased complications for folks. So it's a little bit of a silver lining there.
Not too bad, right? So it's more contagious, but not as virulent, right? So people aren't getting as sick. But obviously still some of the same precautions because we're not quite out of this pandemic yet is one of the salient things that I keep telling my patients. Still mask when you can, get vaccines, follow the trends.
I'm sure you'll get some questions fielded at some point on a shift about this new variant. So a little information for you there. And now for maybe like the biggest headline in the last few weeks.
Yes.
If you're a fan of football at all, part of any
about
fans, Mr. Hamlin's cardiac arrest on the field, obviously like a super traumatic experience for the team, for fans, for society in general to witness. Before we even dive into this, the most important thing is that he's doing great. This is an Instagram post by him. He's actually, I think, discharged from the hospital at this point, fully neurologically intact. How wonderful. We're not going to show the footage of the actual incident on the field because it's a pretty traumatic, but it was broadcast live for millions of NFL fans. So quite an experience that he had. Ultimately, we're going to talk a little bit about Commotio Cordis, which is Latin for getting hit really hard in the chest and then dying. But we'll also explore some of the other things that could be going on too. Like a lot of people on Twitter and headlines have talked about this diagnosis and pathophysiology. But I think it's also important to know that this isn't definitively what happened to Mr. Hamlin, and there's so many other etiologies of sudden cardiac arrest. Even in athletes who get, professional athletes get very comprehensive cardiac screening. There's just too many channels to know all the channelopathies and things that could go wrong.
Right. And then just as far as any of the precipitating factors in that, right? I remember you talking to me about how most of the time when you see Commotio Cordis, it's like the classic one is a shot to the chest with a baseball, something with high trajectory to it. And pathophysiologically, it's right at the peak of that T wave on that repolarization is when it happens. So there are some people that are like, oh, well, was it the hit that did it? Is this what caused him to have this? Is it really Commotio Cordis?
It's going to probably be impossible to ever say. But there's a great review article, many of the things you already mentioned, from New England Journal of Medicine. I think this was 2010, that goes over Commotio Cordis, a rare diagnosis, but the authors here argue that it's probably very underdiagnosed. There's only one known, I think in the United States, one database of cases. I think it's out of Minnesota, the National Commotio Cordis Registry, that's been going around, I think, since the 70s, 80s, that records all these. But there have been reports of people suffering from a sudden cardiac arrest after trauma to the chest since the 1700s. Pretty interesting. And as you said, the pathophysiology here is this idea that you strike the chest wall with something which produces a few joules of energy right at this critical 20 millisecond window during the upstroke of the T wave that then triggers the heart to go into ventricular fibrillation. This is kind of also the same understanding back in the day, if anyone ever delivered a precordial thump to a patient to get them out of VTAG or something, it's generating this small amount of electricity at a very inopportune time. If you look at this data from this review article from this registry, right, the overwhelming majority of these cases are in these projectile sports, like you said, baseball, softball, hockey. Football is listed up on this list. This is cases over 2010 minus 15 years, that study period they looked at the registry. Baseball is just an overwhelming number. And it seems that there's a little bit more competitive sports involved, but probably because people are just playing more competitive sports more regularly than just recreational sports. And you can see by the average age these events happen, it's about 15 years, plus or minus 9 years, pretty wide interval there. But younger people are playing sports, so we'd expect that to be the case. Some authors say that maybe because the chest wall's thinner in younger kids, they're more susceptible to that impact, those joules of energy.
Theoretically.
There's some weird pig models of this. There's a really interesting literature on this of striking pigs and seeing if you can induce VFib, and it's based on the thickness of the wall. But anyways, that's the pathophysiology of it. Part of this registry that we were talking about before is actually looking at the survival rate from Commotio Cordis over time. And from the 70s onwards to today, it's about a 50% chance of survival for a witnessed event on the field, which the authors attribute to like the increased awareness of cardiac arrest, increased awareness of CPR, and availability of AEDs in sports centers and gyms. Every gym that I've been to in the last 5 years has an AED on site. I don't know if you've had a similar.
Yeah,
sort of
and I would say the one saving grace in consideration of what happened on the field, right, was that the medical team actually acted incredibly fast, right? They got an AED on him, they started CPR, they got him off the field, and you can see fully neurologically intact and leaving the hospital pretty soon, or I think he's already left. But so yeah, I would say that medical team needs to be in the Hall of Fame for sure.
Yeah,
that's amazing.
Definitely an incredible save. And I don't know if you've been getting a lot of questions from friends, family, other medical professionals that I work with that don't do as much critical care time about cardiac arrest. It's just been a really good teaching opportunity for CPR, for like awareness of like where's the AED located in your gym. If you run a recreational sports team, like making sure somebody's CPR certified there and knows what to do to prevent these cases in the future. And also that was an interesting societal pause. Everyone kind of really witnessing what we have seen in the emergency department to an excessive amount over the last few years, just dealing with death and cardiac arrest, and kind of this second victims, second trauma mentality that people, have witnessed this really terrible thing, and how do we deal with that? So hopefully, at least for me, it's providing me a little bit more recognition of what family members and other lay people who don't have firsthand experience, have witnessing a cardiac arrest.
All my friends just keep texting me and saying, "Do I have this?" I'm like, I don't know, bro.
Probably be okay. But that's what we got for headlines and bottom lines today. Up next,
Let's start.
Yeah, we've got some clinical images. We're really excited for it.
All right, well,
Let's jump into it.
Oh, sore.
All right, we've got clinical images. We do this every month. Some interesting images, plus or minus videos with some great faculty to talk about their approaches to some of the common pathology that we see. We got Dr. Crager, we got Dr. Nort. Let's get into some images here, starting with our first one. All right, so mom's freaking out, runs in with kiddo who kind of pinged herself against a countertop or a drawer. And she really wants to know, doctor, what do I need to do here? Is this an emergency?
This is an emergency. Now, this is a child, right? So you can see the tooth is up, right? Where we usually see teeth that are either removed and we have to stabilize them or are luxated. You see the height of the other tooth is completely different. Now, the big concern is that it gets shoved up into the alveolar bone, and it can actually cause necrosis of the pulp. So if this is a primary tooth, it's less worrisome, but if it's an adult tooth, this is a true dental emergency that they need very close and dental follow-up because there is risk of loss of the tooth.
Yeah, that is an excellent point. And actually, just to highlight for the rest of the group, kind of some things that so this is a dental intrusion, that's all right. And some of the things that Dr. Nort kind of hit on here, right, is knowing the difference as far as the things that we need to do stuff about and we don't. And that intrusion, right, just like you can see in this picture here, that tooth gets shot up into the alveolar ridge and it's locked into the bone. Don't try to pull that out. It's set, it's there. Versus the extrusion or the lateral luxation, right? Well, this is essentially detached from the alveolar ridge. Sometimes it might still be hanging in the socket, but it's a little bit out of sorts here. And so in this case, Dr. Crager, for as non-critical as this is, let's say that it's not the intrusion, but like an extrusion or a lateral luxation where you got that wobbly tooth and parents are freaking out. Is there anything to do about that?
Wobbly tooth, not a primary tooth, parents are freaking out. Well, the patient's not dying, so I'm not really sure what to do because the patient's not dying, so I don't really know those ones. But, or they didn't aspirate the tooth, I'd know what to do. If they aspirated the tooth, I could go after it. Yeah, if it's coming out and it's not a primary tooth, it was going to come out anyways, so
yes.
That's about as far as I've come with that one. Pediatrics and dentistry, not my strong point.
But that's totally a good point, right? It's just that verbiage to reassure the parents, right? Like I said, if it's a primary tooth and it's a luxation, right, or an extrusion, not really anything to worry about in that regards. And actually, if you want to like get really academic about it, EMA does a review of the Association of Dental Traumatology and their guidelines for how to manage these different things, right? And the main thing about it is, especially in the pediatric population, not a whole lot to do. Let's say it's an adult tooth that has the extrusion or luxation to it. Splinting, what are you guys' approaches there?
You have to and should splint that tooth because you want to preserve as much as you can. So there's lots of different ways that you can splint the tooth, but a quick and dirty one that we have been talking about is if you use the wire from, everybody's familiar with wearing masks now, you take that wire out, you can apply it with some cyanoacrylate and then splint that tooth and then refer them on to dentistry.
Yes, perfect, right? And this is a great video on MRAP HD that we also have playing with Dr. Nort's point here. This is Jess Mason doing it with, if you have the dental box and you've got all the paste, this is her kind of showing you how to mix everything up. It's super sticky. It gets all over anything that's dry. So she makes a point of saying you really want to dry the tooth in that area. Get your gloves wet, maybe use some little KY so it doesn't stick to you. And then she creates a little cigar with it and lays it on there and then dries it. But I'm like you, Dr. Nort, where I don't think we have a dental box. I'm not sure where mine is. So the little MacGyver move for that, like he said, is to take the wire out of your mask. Again, keep that tooth really nice and dry, kind of where Jess is laying that her paste. That's exactly where I would get some Dermabond, dry, yank out, gauze, and then, Dermabond right in there with the wire in place. So quick and dirty splint. All right, let's keep moving. Next image. How good are your physical exam skills?
I don't think they need to be that good to be like, that is bad.
Right.
Nothing good is happening there.
Not a simple cellulitis, I'm assuming you're hinting at, Dr. Crager.
No. And is this patient having a lot of pain, tenderness, unhappy looking sick patient?
So you could say that he is quite uncomfortable. He was, kind of focused on the turkey sandwich initially, but once you fed him, he mentioned to you in passing that nobody's pulled back the covers yet and looked at his leg, and that's what he's actually in the emergency department for.
Surprise. I mean, that worries me just looking at it because the degree of badness looks deeper almost than just a cellulitis. Like, it's not like the entire thing is just like red and hot looking. Like, yeah, there's some redness and but like the bruising, the bull eye, the badness, I'm worried about a deeper soft tissue infection here is the punchline.
Yeah.
That just doesn't look good to me.
And I agree with Sarah. Now, of course, you want to have a differential. So if this guy had zero pain and he inverted his ankle, and this could be a fracture blister, but you can see if you look at the dorsum of the foot, you look proximally, there's other stuff going on. This is not a fracture blister without me even putting hands on this patient. But if he has, or she, but I'm thinking it's a man, pain out of proportion, you're seeing this thing over an hour, rapidly expanding, you better be worried about this one.
Yeah, and also as I'm palpating, if there's pain over the site that it looks the worst, but then I get really concerned if I keep palpating up and there's pain where it doesn't look that bad on the surface, that really, really concerns me. I actually had a patient the other day who came in with the chief complaint of knee pain. They actually ended up having Fournier's, but how I ultimately got to the Fournier's was they were like, my knee really hurts. And then they hurt a little up and a little further up the side. And then they really obviously hurt when we got to the Fournier's part. But yeah, whenever I'm having pain out of proportion distal from the site that it looks the worst, like it's far away from where it looks bad, I start getting really, really concerned about neck fash.
Yes, and you know what? The reality of this is, I don't know about where you guys work, but where I work, we do a lot of hallway medicine, unfortunately. And so it's always harping on my residents about, did you look at the skin? Did you actually roll up the guy's pant leg and examine that way? And just again, there are some people are a little labelle indifference about certain things, right? And again, like you said, how many times have you pulled back the curtain and you're like, why didn't you tell anybody that was there? So kind of just making sure that you're being really solid on your physical exam. And like you said, if it doesn't make sense, this isn't a slam dunk or clear cut cellulitis, right? We've got to be thinking about the super sick things here. And so this, like you're all hinting at, is necrotizing fasciitis. And the one thing that I wanted to point out about this, and just looking at our literature, saying how good is our physical exam, right? got a couple of EMA papers here where they actually looked at the accuracy of physical exam against imaging, against the nice fancy lethargic score, right? And looked at the sensitivities as far as if you use that in isolation, how good was that at being a clinical indicator that you've got neck fash? And obviously the sensitivities looking at physical exam, just bullae, hypertension, or fever, right? Bullae, 21% sensitivity, hypotension, 20%, fever, 46%. So none of those perform very greatly, obviously, in isolation. Same thing when you look at the lethargic score that we all talk about. Or I really only talk about it when I'm trying to convince the surgeon to do something. That's the only time I use that thing. But how it performed, right? So a lethargic score greater than 6 was only 68% sensitivity, and greater than 8, the sensitivity dropped to 40% there. And then obviously there's no question that, like you're saying, you know, if your spidey sensitive tingling, you're going to be looking towards, you know, getting more imaging or getting surgery on board ahead of time. Imaging performed the best, with CT imaging obviously being at 94%, looking at gas versus fascial edema. And if you had the fascial edema, then the percentage increased there. And so that's just something to kind of be mindful of as far as like, it's not just physical exam or this scoring system alone that should be like you getting the surgeon on the phone for.
I think there's probably worth spending a few more minutes on this one because it's so important. So examine them often. Do repeat exam. This is a surgical disease. You have to get your surgeons in there early. There are some things though. If you see a white count that's 25,000 and they're hyponatremic and you better be really seriously considering this. You don't always have gas-forming organisms and you don't always feel crepitus. So that's something sometimes we'll do. We used to do a lot of cross-table laterals and say, oh, there's no gas. This is polymicrobial very often. So the other thing that often comes up, and I think it was one of the questions, is which antibiotics first?
Yes.
Our nursing colleagues often will give antibiotics in the order you order them. Remember, vancomycin has a protocol at most hospitals of 2 hours. If you write vanco first and you don't tell them not to give vanco first, it's going to be 2 hours before they get probably any antibiotic in there because that's going to be running. So generally I'll say, whenever I'm feeling as this more gram-negative versus gram-positive, I'm either going to start with Clinda or Zosyn and tell the nursing staff, get those in as fast as possible, and then if I'm going to cover vanco or something else in addition to that, right? So there's a lot of different antibiotics you can use, but if I'm really worried, I'm calling the surgeon, I'm using Clinda, Zosyn, followed by vanco.
Yeah, exactly, Clinda first, basically, to get the toxin.
Right.
And I think that we should just do this always when we do antibiotics, because if we write for 7 antibiotics and don't tell them what to give first and have 1 IV, you know, how are they supposed to know? And so I'll usually specify, and in this case, it really matters you give Clinda first. And I think also, this seems obvious, but in real time, if they don't have a working IV, they can't get any of the antibiotics. Just because I write for something doesn't mean it happens. And so if I really want that antibiotic in, I'll like go make sure they have an IV and be like, I want to see the Clinda hanging and wait until, you know, wait at the bedside till it happens often.
Yes.
That's the way to get things done.
Absolutely right. And nursing protocols and pharmacy protocols are generally going to be only 1 antibiotic at a time because if they have an allergic reaction. So you could say, hey, we have a triple lumen, run them all in. They often will not be able to do that based on protocol.
Yeah,
Right.
totally.
So take-home message here, right? This is not one of the ones that you walk away from the bedside on. This is one of the ones where you're really being active as the physician in charge of the care, making sure things get done expedited in the correct order with the highest priority for these patients because they can spiral down the toilet real quick. All right, so let's go on to our last clinical image here. Who is sending the intern to close this one at the bedside? No biggie, right?
Oh yeah, totally. The medical student even. Yeah, just close it up, whip stitch it, all good. What could go wrong?
Dermabond. Go home.
That's the one. That'll solve it. Yeah.
So what do we think about this laceration? I guess the biggest thing is like obviously the location of this, right? This is suprapatellar, and so anytime that you get something there, did this violate the joint space or not?
That's the one. Where does it go? We can see where it starts. Where does it end?
Right.
I have no idea. But we need to explore it.
Yeah, you
literally,
do. So
I
if it's
suppose.
in proximity to a joint, you always have to presume that it could have violated. So what are you going to do about that? There's a couple of different things you can do. Traditionally, we've done the saline load test that was often combined with methylene blue, with methylene blue thought to be a good marker. Studies have shown it really isn't that good of a marker, and it may interfere, causing a little local irritation and inflammation. So methylene blue, for the most part, is out. Often people, I think, are a little, because you'll make their joint should get uncomfortable. When you do a saline load, you have to do enough that you actually see the joint is expanding. So you have to give enough volume and give your patient analgesia or let them know that they're going to feel this, because if you don't give enough, you're not going to see the saline coming out. And then Whitney, I'll throw back to you to talk about the difference between imaging and not, but there's a lot of debate whether saline load alone or imaging alone, or I think most of us are doing a combined approach to both.
Definitely.
Both of these.
Yeah, I would say, you can get as academic as you want about it. I think my area of comfort, and we just saw a great video by Jess Mason as Dr. Nord explained the saline load test. 20 cc's directly into the joint space after doing some local anesthesia is what we saw there. And you're looking on the opposing side to see if any of that fluid comes out. Don't forget, Jess says it at the very end of this video, take the saline back out, because it really does hurt. And so that's a great way to kind of, diagnostically bedside challenge. But I think the reality of it is, like you're referring to, Dr. Nord, I'm going to get imaging on this as well. And then the last interesting tidbit that I wanted to bring up about this has to relate to where we're looking at now with some new novel thoughts on traumatic arthrotomies and if they all have to even go to the OR, which I didn't really think about before. For me, I'm like, nope. OR, washout, admit, I'm done. I'm walking away from this. But actually, EMA just covered a paper. It was a non-randomized prospective trial. It was very small, but it actually looked at traumatic arthrotomies and some that were managed non-operatively with just a tetanus, antibiotics, and splinting versus the ones that actually went to the OR and saw how many of those developed a subsequent septic arthritis. So the caveat here is, of course, the result was that only one case in the non-op got septic arthritis and 9 cases in the operative. However, the operative ones were actually larger and more contaminated wounds to begin with. So again, this is not necessarily something that's practice changing. You're not just, doing a saline washout at the bedside and sending that patient home. It's just something new, interesting that ortho's looking at. It might be reasonable to talk with and make shared decision making with your ortho consultant. So just thought I'd bring that one up here because this is kind of one of the latest EMAs that came up, and I thought it was interesting related to what we were talking to. So, all right, and let's close things out. Who's ready to win some AirPods here? We are going to do the mystery image, and now that we've got the one and only Sara Crager, we're going to let her tell us, what are those?
Yeah, so this was a patient that I had, and I get called by the ED, and they're like, look, there's this 26-year-old guy, and he came in, fentanyl OD in the field, and that's something we see all the time, but fentanyl OD in the field, came in, brought in by EMS, he got some Narcan, he came in, and initially when he came in, he woke up, he was awake, he was talking to us, and then pretty rapidly he started saying he couldn't breathe, and before we even had a chance to get a chest x-ray, he completely fell apart, got profoundly hypoxemic, was breathing at 40-some, and they ended up having to intubate them. So the ER doc calls me and they're like, his chest x-ray, it looks awful, but it also looks weird. I don't know what I'm seeing. I thought maybe he just aspirated or something when he was out, because it sounds like he was pretty out from this fentanyl overdose, but that doesn't quite look like that's what happened.
Yeah.
And he was so sick. It was not good.
Well, there you go. Dr. Crager has laid the foundation for us. ED doc, not really sure what he's seeing, but we want everybody to take a close look at this image and drop it in the chat as quickly as you can, because the first person to tell us what they think is described here on this chest x-ray will get some AirPods. And we will follow up at the end of the sesh to come back, and Dr. Crager will finish out the case. All right. Last chance. Take a look. Type. All right, and that will conclude the clinical images for the evening. Now, just a transition. If any of you have ever been in a sorority and you like playing sorority games, we're going to kick it off and go on to something called Two Truths with Dr. Crager.
Oh, sorry.
How did you know that I was in a sorority? Damn, you caught me. Hey everybody, so we're gonna play a fun game tonight. Two truths and a lie. I don't know, it's like a pretty common drinking game, meeting people. I don't know, have you guys played it before?
You're all cooler than I was in college and high school.
I was just gonna say, I'm too cool to play that.
And I'm not cool enough to have played
Right,
it, so this is our
just
first
you.
time. It's just
you, bro.
You're right in the middle of intermediate
we got
coolness.
40
the
minutes
one.
left. It's going to be a long 40 minutes, guys. Well, anyways,
Literally.
great. So in case, you're like our guest here and haven't played this game before, quick explainer. So
Guys, you're cool.
we're going to go around
Exactly.
and
We're
we're
not
going to present 3 facts, right? Or 3 statements, I should say. 2 of them will be true. One of them is going to be made up, fudged a little bit, and then the other 2 people are going to have to guess which of the statements is a lie and which other 2 things are true. So hopefully we'll learn some maybe fun medical facts, tidbits, some actionable stuff for our next shift. Who knows? I don't know what you guys have concocted up here as your lies or your truths. In the chat or on Slido, actually, I'll bring up the slide right now. You join in. We'll have a quiz that runs in real time as we're describing these things. And the winner, which is in accuracy, you caught all the lies and you did it the fastest, we'll get another set of AirPods. We're giving away a lot of AirPods tonight. It'll be good.
We got to get some.
Okay, ready.
You guys ready to play?
Are we in the running? Do we get AirPods if we win?
We-
Is
I
that
don't
really
think so.
gonna run? Okay.
I think it's more for the home people, but hey,
No,
we'll try,
not motivated. You told me that time. Okay.
we'll try to make the dream happen. So let's jump into our first one. You guys ready? I'll
Ready to
start
go.
it off. I got some right here for you guys. All right, so my first set of 2 truths and a lie. Okay, 1, a urinalysis is not needed to diagnose an uncomplicated UTI in a woman. 2, grip strength is a sensitive neurologic exam maneuver for focal cerebral lesions. Or 3, weight-based glargine, a long-acting insulin, can be given while initiating an insulin drip in the treatment
Wait,
of
are we supposed to be yelling out truth?
No, you guys can talk about it. Yeah, you guys can figure out which you think
Phone a
is the
friend.
lie.
Got it.
Well, 3 is true. I'm running with that one. I like number 3. I call that truth. That's truth.
Okay, giving insulin to DKA, probably a good thing. Probably a
Yeah,
good thing.
okay. That sounds good to me.
And yeah, uncomplicated UTI
Yeah.
symptoms.
Right, totally.
You
Dysuria.
guys order UAs all the time, though. You dips all the time.
Yeah, but we order all kinds of stuff all the
for
time. That doesn't
billing.
mean we need it.
It's for billing.
And for billing,
Sure.
obviously.
Okay.
I mean, it just seems to be like grip strength can't be a sensitive indicator of
neurologic
anything.
Exam maneuver for
Like
focal
focal
cerebral
I mean,
lesions.
I'm going with that one.
I mean, I guess
that
if
one just
it's
doesn't make any
neck
sense.
injury,
to
then
maybe
the grip strength.
Grip
is
strength?
the
then
thing.
next, yeah, I'm going with that one's a
All
lie.
right, you agree? Grip strength is a lie? Less convinced?
Yeah, no.
All right,
Lies.
guys, we're just gonna
Okay,
be
number 2's a lie.
All right.
And?
Well,
Ah,
Tommy.
ah,
Yeah,
success.
so number
Come on,
2 is a lie.
AirPods.
So we
We
can look
don't
at what
get
the
AirPods, remember?
audience
We
had to
just
say
said.
here. Looks like most people picked number 2 as well. We can dive into there is some evidence behind these things, and just make these statements up.
They were so much more obvi than we were.
Yeah,
like,
yeah,
they
they
were
were
pretty
pretty
well
well decided
and
on
faster
that.
than
They were like, shut up.
Obviously, people stop
So let's
talking.
jump into these statements. So about the urinalysis not being needed to diagnose UTI. So I don't know if you guys have read the JAMA, like Rational Clinical Exam Review series. Incredible systematic analysis of physical exam findings and like pre-test, post-test, all the great Bayesian probability you know and love. They looked at UTI, uncomplicated UTIs in women, and it turns out if you have at least 2 symptoms, the post-test probability of using the history as an exam maneuver is so great that actually even like a whistle clean urine is probably not powerful enough to say that that patient doesn't have a UTI. It's kind of interesting. So a lot of as you suspected, a lot of the urinalysis we're ordering probably unnecessary in making the diagnosis. Their algorithm too even recommends being a little bit more cautious about sending a culture too in the right patient population, all that good stuff. The other truth, glargine, long-acting insulin, and the initiation of an insulin drip. It's something I've started doing in the last year a lot. I don't know, do you have inherited a lot of patients that have had that started in the ICU? or
Not
no?
yet, but I kind of wish I did. Like, I feel like that would speed things up a little bit.
Yeah, I think it's wonderful. It prevents patients, in my experience, from like kind of falling back into acidosis if there's like any problems with the insulin drip or pausing, starting in the ED. There's a great pilot study that's linked right there on the slide that kind of shows this data in emergency department population, but there's a lot of good safety and efficacy data, obviously, for long-acting insulin in general.
No, I think it's fantastic, especially because inevitably you're going to lose an IV, and then, oh wait, they don't have one, and then we can't start the insulin drip, and the next thing we know, 7 hours later, still no insulin.
Yep.
So no, I love this.
Oh my gosh, yeah, the
the
delays
time.
from pharmacy.
Oh, yeah,
You ordered the
inevitably.
drip, but you ordered it wrong, and I didn't use the order set correctly, and
Every
yeah.
time, yeah, I do that every time.
And it's like super safe too. You know, like the drip you're titrating. So like if too much long acting, like you can turn down your drip rate. It's great. And then the lie is yes, the grip strength exam. I feel like you look at like a few rapid stroke scores, like the LA Rapid Stroke Scale uses grip strength as one of the markers. But if you look at, there's one great paper that's cited here, actually using grip strength as an independent marker when you ask neurologists, like does this person have a focal lesion? really, really terrible test characteristics. Like the sensitivity of just grip strength in general is in like 30%. Very specific if they do have it with some other upper motor neuron signs, but it's just fascinating because I always feel like we ask patients to squeeze their hands. And,
Totally. I do it all the time.
Yeah, and also kind of makes sense. If you just like,
squeeze.
if you hold your arms out, why pronator drift is so much more sensitive. It's like, you can feel it requires a lot more muscular effort to maintain this than to just keep your arms naturally in this pose, in a flexion pose. So that's it. You guys got me. All right, who's up next? I think you're up next,
Am I up
Sara.
next?
You're two truths and a lie here.
We go. Ready? All right. Number 1. Nearly half of critically ill septic patients admitted to the ICU have a normal lactate. 2. Over half of the patients that meet sepsis criteria in the ED do not end up with a discharge diagnosis of sepsis. And number 3, left ventricular dysfunction in septic shock is associated with significantly increased mortality. I feel like I should play some Jeopardy music.
I know.
Yeah,
Start
right?
like humming. Or what's that?
I'm just thinking about all of the influenza patients that come in and they get a code sepsis called on them, and then I discharge them with influenza. So I feel like 2 has to be, over half don't end up with it. Oh yeah, I feel like 2 has to be true.
Yeah.
You could have like, some of the other the tachycardia when you come in, and maybe you're a little tachypnic, and
Yeah, I think I'd have to
Thursday or
agree with that too.
whatever,
It's also like a kind of like a little dispo diagnosis where you're like, oh, this person's really sick, sepsis.
Right.
We'll put that on the chart because all that fact was studying. Maybe it's just like a chart review, I have no idea about the left ventricular dysfunction. I know it happens a lot. Whether people die more because of it or it's just like a fun little bonus to your septic shock. Hard to tell. I will say for the number of lactates that we order irresponsibly, I have no way of predicting for number 1. Yeah, I mean. So I don't know. I'm down to guess 3. I don't know. What do you think?
As the lie or as the truth?
As the lie. I don't know if it's a mortality thing.
I feel like it's Sara Crager, and so number 1
The queen of
has
the
to,
RV,
right.
so it might,
Number 1 has to be true, because if you've heard her lactate rant, it's like going to church.
Yeah.
Preach to me. So yeah, I'm gonna go with you on that one, Governor.
All right. Let's see what we got.
Yes! Success.
All right. Tell us a little about this.
Amazing.
Yeah.
All right,
Crager
so
rant.
here's the thing. We send lactates all the time. Turns out, if you look at not just they may have man flu and didn't need a lactate in the first place for sure. Well, of course not. Of course those patients don't have a positive lactate. But if you actually look at patients who have high organ failure scores, they're sick enough they legit need to go to the ICU from sepsis, half of those patients still don't have an elevated lactate. That's the interesting bit. And we look for it, and all the time we'll be like, oh, this patient's not that sick, they don't have an elevated lactate. But it turns out you don't have to. We see it all the time.
Their pyruvate cycle and that Cori cycle just crushing it. Just clearing that out.
Clearing everything.
Yeah.
So yet another case of lactate. Does it mean what you think it means? Often not so much. Yes. Next one. So we're bad at sepsis in the ED, but it's not our fault. It's because somebody hands us these criteria and they're like, we have decreed if they meet these mostly random and not very evidence-based criteria, they have sepsis. And it turns out, no, not so much. There was this great study that came out in 2021, basically finding that if you look at all the patients in the ED who meet sepsis 3 criteria, as isn't this an old-fashioned sepsis 1, this is newfangled sepsis 3 criteria, about those patients who really, they should be septic in the ED, about 60 to 75% of them are not going home with a discharge diagnosis of sepsis. And this study wasn't just ICD-10 code. They actually looked and they were like, well, if they had an infection and organ dysfunction as 2 different discharge diagnoses, they still counted that. Even then, the vast majority of patients we see who meet sepsis criteria in the ED don't end up actually having sepsis.
Wow. So is your takeaway from that, when we're calling something septic shock or sepsis, we really need to take a much harder look at that, especially if we're going down a treatment plan here.
Totally. And if we're using this to be like, oh, they meet sepsis criteria, let's give them a bazillion cc's of fluid for absolutely no reason whatsoever, we probably shouldn't be doing that. But also, as we'll talk about later, a lot of these patients may be in shock. It may just not be septic shock. And I think one of the big things we do in the ED that has major consequences for patients once they get admitted is just being like, oh yeah, septic shock. We'll just admit them for urosepsis, sepsis this. And then everybody anchors on that and fails to notice that they have cardiogenic shock or something else is horribly wrong with them. And then the last one, this one is one of my favorite stuff that came out recently in the literature. So we've known for a long time. Septic patients often have cardiomyopathy. It's a thing. And like half of them in some studies will have some left ventricular dysfunction. But what's been really unclear is, does it matter? Like, are we just like echoing everybody and being like, yeah, they got some dysfunction, cool, whatever. It's pretty unclear that does it matter or doesn't it? What's becoming increasingly clear with a couple studies that came out recently is that LV dysfunction doesn't seem to be associated with increased mortality. But more interestingly, RV dysfunction does. You knew I was going to hit the RV. You knew it in your face. You knew. But interestingly, yeah, patients with RV dysfunction, that does seem to be increased mortality. And a lot of patients have it. Depending on the study you read, about a third to some studies, even a half of patients in septic shock have RV dysfunction, and it seems to clinically matter.
Wow.
See, the RV is the best, or the worst.
Spend some more time
depending
looking
on
at that
perspective.
RV. Next time
we
you
go.
get that hypotensive patient, I'm just calling septic
See?
shock and admitting blindly to the ICU.
You're my favorite human. There we go. Strong work. Look at the RV.
But also ordered lactate. Just for
But also ordered
Just,
to
just to sprinkle it on there.
just for
All right, you're up. What do you got for us?
All right. Here's mine. Somewhere. Here we go. Okay. So IV contrast must be avoided because this exacerbates muscle weakness. So sorry, I should be set the stage here. We are talking about myasthenia gravis. So this is the pathology we're talking about, myasthenia gravis. So in myasthenia gravis or myasthenia crisis, IV contrast must be avoided because this exacerbates muscle weakness. 2, patients are considered to have impending respiratory failure if they cannot count to 40 to 50 in one breath. 3, infection is the most common precipitating factor for myasthenia gravis crisis.
I feel bad about this because I don't know if I can count to 40 to 50
I was about
in
to
one.
say, compared to, I'm pretty sure I can't do that.
Yeah. But at the same time, I think one can't be true because otherwise, like I've done a lot of bad things to a lot of people with IV contrast. I mean, I don't see that many myasthenia gravis patients, but like no one's ever told me like, hey, listen,
Don't
do that with me.
myasthenia gravis population.
yeah, well, I mean, like how hard have we had hammered into us like with our assignment, like paralytics and myasthenia? Someone would have told me about this. I feel like
You would think
You'd
that,
think.
but maybe
You'd
we're
hope.
about to
Maybe
discover
we're about
not
to-
so
yeah.
much. Who knows? But I do know that, or at least what I think somebody taught me once, was that one of the most specific or maybe sensitive things for are they having impending respiratory failure is can they count to some number?
Okay.
Like not a NIF, not a whatever. But I don't think it's 40 to 50 because that sounds really ambitious to me. I was going to think like 10, maybe. Sounds more realistic.
I think I'm just very out of shape. I think that's what it comes down to.
Yeah,
I have
that's
a
also
poor,
possible.
like vital capacity.
Everybody
you know?
else can count to 40 to
Yeah.
50, but I'm going with, I think 2 is probably, well, I don't know.
You're gonna say 2 is a lie. I'm gonna say 1's a lie. I'm going 1 is a lie.
Okay, that sounds reasonable.
Because I just like want to feel better about myself and that I didn't hurt people. You know.
You're
giving-
pushing all that contrast.
But 3 we can agree. I think.
So many
sure.
contrast
Yeah.
3 we
studies
can agree
going
on.
there.
Let's see. What do we
Okay,
got?
let's find out.
Survey says
40 to 50.
Number
Everybody's
one.
in so much
That's a
better
lot.
shape than I am.
So before we get into the academicsness of this, let's talk about this single breath count because I heard this from Mel Herbert and Squadron. They were talking about it, and we need to do it. So what we're going to do right now is we're all going to take a breath in, and as you exhale in one breath, see how high you can get.
How fast can you count? As
You
fast
can
as
get
you want?
count as fast as you
Okay,
want. Here we
good.
go.
Then
We're
I
all,
might do
we're all
okay
going to
here.
see if we
All
need
right.
to be intubated or not. Ready? 3, 2, 1. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16,
This is gonna be
17,
really
18,
fun to audio edit later.
19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 40, 41, 42, 43, 45. It's abated.
Yeah. All right.
Yeah,
so
totally.
Very clearly true.
Okay, we win. Extubated over here.
Single breath count. Don't forget, number 2, check out Corpendium. It's in there, and I learned it from Mel Herbert. Infection is 100% like one of the most common precipitating factors, truly testable. And IV contrast being avoided because this exacerbates muscle weakness. Old school of thought here. The studies that came out about this were all related to old IV iodinated contrast, and in that case, there was like a 3% chance that you were going to precipitate some weakness. Now we have new technologies, new contrast, but no new studies yet that have really ventured to look at this. So it's kind of like Kobner said, it's probably okay just based on all the new water-soluble stuff that we're using in different tech.
So added to the list of IV contrast myths, which is getting longer and longer.
Yeah.
the more studies we do.
Well, it seems like the people at home looking at the Slido, they're also a little skeptical of number 2, the counting thing.
40 to 50, right?
40 to
That's
50
a lot
seems
of
like a lot.
numbers.
Seems like a lot.
Check it,
Very
check
reasonable.
it.
Very
We've
reasonable.
got a ton of material on myasthenia gravis on MRAP. Everybody, let's study
Let's check it
together.
out. All right, let's shoot through these. I think we have one more round. Let's
Okay.
let's do
All right.
rapid
Okay.
fire.
Here we
Rapid
go.
fire.
Okay,
to
real
face
quick,
them
real
all.
quick.
All right. So here we go. So number 1, Boxer's fracture of the 4th and 5th metacarpals do not require an ulnar gutter splint. 2, pelvic exams performed by emergency physicians have a high degree of inter-rater reliability. And 3, hand lacerations less than 2 centimeters in length do not require suturing for cosmetic outcomes.
I like how you put.
I picked a lot of critical care stuff for
Yeah,
Sarah.
I like how you put a
Just
pelvic exam in between 2 ortho subjects.
None
really
of which
trying
are
to
my
get,
strong point.
Because now my eye is drawn to that one. Hold on, okay. Wait.
I mean, inter-rater reliability for what? For like the cervix is present. I would, yep.
For,
probably,
sorry, I should say an
hopefully.
abnormal finding. An abnormal finding. Yeah.
I mean,
Okay, rapid fire.
Some great questions.
We're gonna go.
That's fair.
Count of 3. 3, 2, 1.
2.
2. All right. Survey says
And
2 is a lie.
success
Yes.
again. Ta-da.
Absolutely. So it's actually
their pause anyways.
super poor inter-rater reliability in one study of emergency physicians, where they actually, it's a really interesting study. They had a whole bunch of patients. They consented to 2 pelvic exams. So when the first clinician identified any sort of pathology, whether it's like adnexal tenderness, a mass, like a whole gamut of things, anywhere between 17 to 33% of the time, the second clinician could agree on what the finding was. So it's pretty low inter-rater reliability on that, which if you think about, I don't know, like we talked about it at the great pelvic exam debate a few grand rounds ago, it's pretty rare that people like follow up and do like a repeat invasive exam to help you confirm. Sometimes you can talk to your like OB colleagues to get a better idea of feedback on your exam skills, but to me, not surprising that this is like such a poor number. As far as the centimeters lacerations on the hand thing, so there's actually some evidence that less than 4 centimeters, I'm not talking about like, you know, a tendon that's cut or, you know, just a purely superficial laceration might not require suturing for cosmetic outcomes, but there's great data for if it's less than 2 centimeters, if you conservatively manage it, which is the polite ortho way of saying put a Band-Aid on it and send them home, it looks just as good as people who get sutures. And the patients in the study report better pain scores, you know, it's like less annoying for follow-up, all that good stuff, something to consider. And then finally, we're talking
Splinting.
about the splinting, yeah.
Yeah.
So there's a lot of great data. Like at first there's some data that talked about not doing an ulnar gutter, but just wrist immobilization. And now all these functional like metacarpal immobilization tools where it's actually a little bit more of a flexible application of a splint, like a commercially available product with a well-reduced Boxer's fracture, especially the 5th metacarpal. You can get away with doing that rather than this awkward, you know, like long-term mobilization. More you know.
Fancy.
All right, what do you got for Sarah for
All
your
right,
next round?
moving along to item number next. Okay. 1, patients in cardiogenic shock frequently meet SIRS criteria. 2, IV fluids just can improve elevated serum lactate. And 3, patients with cardiogenic shock may be normotensive.
I'm going for it.
What did you say, 2?
Yeah.
Yeah, I think that's 100%. That's 100%
You know me
alive.
too well.
Yeah, definitely not. Let's see. What do we got?
Yeah, there's the one. Okay. I'm not going to go on a long rant since apparently I've maybe been on that rant for you before. I'll just go on a little bitty
my
short
favorite.
rant. Okay, well, see, it's your favorite. So now I can go on a little rant. Look, it depends why your lactate's high. Lactate is not all about sepsis. Okay, well, there we go. We'll just rage a little more then since I've been explicitly given permission here. Yeah, lactate is not just about sepsis. If your lactate is high, fluids may help it. If fluids help improve your perfusion and the physiologic stress your patient's under. If your lactate is high because, oh, say the patient's in cardiogenic or some other kind of shock, fluids will not help you. So that one's the lie. The truths are interesting. So interestingly enough, SIRS criteria, which apparently, you know, at least according to the last studies we talked about, doesn't seem to help us diagnose sepsis very well, turns out actually see it all the time in patients with cardiogenic shock. There was a study that came out, retrospective review, 9,000 some patients admitted to the cardiac ICU. Turned out about 1/3 of those patients were positive for SIRS criteria. And I think for me, the bottom line with this is this idea that we're increasingly embracing, where we're differentiating the shock precipitant from the shock pathophysiology. So, you know, all comers, cardiac patients can have SIRS as well. And then finally, cardiogenic shock can present normotensive. A lot of these patients actually probably do present normotensive.
It's frightening.
And it's so scary, right? And a lot of the prior literature, well, part of the inclusion criteria was hypotensive for cardiogenic shock, so we have some circular reasoning here. Some of the newer literature that doesn't make hypotension a criteria for being in the study, one of these studies actually right here found that 50% of patients with cardiogenic shock were actually normotensive, which is terrifying. Right?
Yeah.
See, thought I would just scare you before we
Nothing like
move
a
any
little-
further.
Little Sara Crager fear to get the blood pressure going up. You should just tell that to your patients to get them
Exactly.
normal
Then they'll all
tension.
be normotensive.
Nothing like a Sara Crager rager to stop the game.
Yeah. Well, you know, this might actually be a good segue point for our next segment.
This is the one.
Jumping off from here.
Drumming up interest.
Yes, let's
Yeah.
hear more.
Let's hear more about this. So let's check the slide and we'll see who actually won, whoever was following along the fastest, the most lies identified. We're going to cut right now to a really amazing video on part of our On Doctoring series that we did, part of our MRAP 1 conference that happened. God, I can say last year now, it's 2023. It happened last year, last spring. It's a really great series of videos. Check it out on MRAP HD. This is just a small clip from it, and Billy's going to talk about what it means to him to be a doctor. And then we'll see you right after that with our Experts Corner.
We can talk about what makes medical education. Is it great teachers? Yeah, they're great to have. Is it great students? Gotta have great students. I love having great students. But the hardest thing in what I call the triangle of education is the patient.
Well, anything else you'd like to share with the MRAP community that'll be watching?
Oh, I don't practice now. I've had a stroke. I miss it terribly. So for those of you who are inclined to bitch here and there, I get it. But it's still the greatest job ever. Teaching residents is the greatest gift ever. And so for those of you who can still go in there and say you're Dr. So-and-so and interact with them, take it for what it's worth. It's a beautiful thing.
Experts Corner.
With
All right, Sarah, you scared us enough in some two truths and a lie about cardiogenic shock. Let's pick your brain. Let's pick your expertise a little bit here. This is one of my favorite, I guess, critical care topics. Also most terrifying, I think, clinically, because I feel like so often, like, what do I do with my hands? Because like you try a few things and like I can't do ECMO, I can't take someone to the cath lab. So I'd love to ask you a few questions about what we can do for these patients.
100%. Fire away.
Yeah, so I know we've talked a little bit offline about some vasoactive agents we can use to help these people. You alluded to there's been some changes in what we should give and what we should do. I mean, I feel like you go to rounds at USC, we have some like a seasoned attendings that will tell us, oh, back dopamine was the best thing. Then it was not the best thing. Then Levophed was great. So where are we? And like, what is the history of, I guess, vasoactive agents in cardiogenic shock? What do we have to look forward to?
Because there's a lot of controversy here. I mean, it's easy when we have septic shock. Everybody's like, Levophed, call it a day, all good. I think pressors in cardiogenic shock are a much more complicated and controversial topic.
Okay.
This is a brief history of pressors in cardiogenic shock. You know, things really started with this debate when the DeBaker study came out, and that was in 2010. And basically, the upshot of this study, multi-center, prospective, randomized controlled trial. And the key finding was that if you randomize people to getting either dopamine or norepi, the patients, the subset of patients with cardiogenic shock, higher mortality with dopamine. And this was a big thing because, you know, that's what you would give for cardiogenic shock. Dopamine was the thing. And this was really good data, and it seemed pretty clear patients died more often with dopamine. So then we were like, okay, just kidding. Maybe we shouldn't be using dopamine for cardiogenic shock because it seems to kill people. That's bad. So what should we be doing? So then there was another study, small study came out that was like, well, maybe a little norepi, add a little dobutamine, and let's compare it to epi. And it seemed like the norepi-dobutamine combo was maybe a little bit better, but unclear because they didn't have mortality as an outcome, and it was mostly in terms of side effects and lactic acidosis. Then we're like, okay, let's check a couple other things. And this was a big one that came out that freaked a lot of people out. And this one was looking at norepi versus epi in patients with cardiogenic shock, specifically after an acute MI. And a lot of people read this study and were like, epi's the worst. Epi must be the devil. Because what they found, it wasn't a big study, it was 57 patients. But what they found is that in acute MI, the patients who got epi had worse, quote, refractory shock. Now, part of the issue with this study is that part of their definition of refractory shock was high lactate. And epi itself can make your lactate high, so it's a little hard to know what to do with this. But based on that study, everybody was like, okay, we shouldn't be using epi in cardiogenic shock with acute MI.
It's kind of a brilliant endpoint if you're trying to like disprove epi. You're like, well, it causes the thing we're trying to. Yeah,
Ta-da!
that's pretty good.
And there were other pieces to that, but even so,
Sure,
you're like,
sure.
well, I
A little
don't totally
suspect.
know what this means.
A little suspect.
So we're still trying to figure this out, but at some point in there, finally, about 7 years after the initial DeBaker study came out that was like dopamine's bad, finally everybody got on board, and the AHA was like, okay, well, we guess we at least shouldn't be using dopamine. The official recs came out. The AHA and the European Society of Cardiology were like, yeah, actually, probably norepi should be first line for this. And so then everybody really, if they hadn't gotten on this bandwagon that we shouldn't be using dopamine, they were getting on the bandwagon, and everybody started using Levophed. It took a while, but we got there. But at the same time, we're like, well, that's not really an inotrope. And don't we kind of need an inotrope? So then people started saying, okay, dopamine is bad, maybe we'll use Levophed first line, but what about, helping the heart squeeze? Don't we kind of want that in cardiogenic shock? So then we started looking at milrinone versus dobutamine. And there was the initial study that came out looking at them being like, milrinone wins. You get less arrhythmias with milrinone, and that's significant because probably the issue with dopamine and that initial study, the DeBaker study, was arrhythmias, right? Dopamine, very arrhythmogenic, and that's probably why it was killing people. So now we're looking at, okay, milrinone versus dobutamine, and maybe milrinone was better for adverse events in this study.
Okay.
Then they did a meta-analysis. And everybody was like, yes, we have an answer. Milrinone is the one to rule them all, because this meta-analysis looked at all comers. It looked at dopamine, dobutamine, Levophed, milrinone. Everybody found milrinone was the best, call it a day, until another really good study came out. And this one was a randomized controlled study looking at milrinone and dobutamine and found that they were tied. As this is all going on, everybody's like, I don't know, man, like this seems like a mess. I'm just gonna keep using Levophed, which was going fine and dandy until recently. Because in 2022, a study came out and now everybody's like, wait a minute. I thought dopamine killed people. Turns out maybe does norepi now kill people?
All right, this is where I have to put my foot down. I mean,
Yeah.
I love the recommendation of just start the Levophed because it's for norepi. It's very comfortable. I know what I'm doing. I dose it regularly.
Feel good about it.
The rest of this history.
Feel good drug.
Yeah, it makes me feel very confident in my decision not to pursue critical care fellowship. I don't have to keep up with this, so I can let you tell me what I should give. But now I'm not allowed to give Levophed or norepinephrine as my first line. So what's going on with that?
What on earth is happening? This is an excellent question. So this was the study that just came out. And it looked at norepinephrine use in cardiogenic shock patients, and it looked at mortality. And this is what they found. They did a retrospective study. They looked at a big critical care database. They ultimately used propensity score matching to get 440 some patients controlling for confounders. Here's what they found. They found their 30-day mortality, so, solid patient-centered outcome patients tend to care about. What they found is that the norepi group, the patients who got norepi for cardiogenic shock, had significantly higher 30-day mortality than the non-norepi group, 41 versus 30%. Now, they didn't find significant differences in long-term mortality. And they followed these patients up to a year. And they didn't find significant differences in long-term mortality, but they did find differences that matter and that seem clinically significant in terms of, in addition to the 30-day mortality, some of these in-hospital things. And so these patients required significantly more mechanical ventilation, and they were in the ICU a lot longer. So this was the study that came out recently, and now we're like, okay, we all just got accustomed to using norepi.
Yeah.
Well, now what?
How much of this can you actually attribute, though, to using norepinephrine as like a first-line agent? In this study, there's a lot of set it and forget it vasopressor use being administered. Like, all right, we got them on the norepi, we'll titrate it up. Maybe this group that required more mechanical ventilation got a lot more flu. Like all these other things. Kind of maybe we're not thinking as cleverly about how we can kind of move some of the knobs and levers with the other agents that we have. Is that kind of your take on this?
Totally.
Maybe?
I think that what this tells us is that for something as complicated as cardiogenic shock, it's just complicated. It's never going to be as simple as, aha, there is a single pressor that we can show definitely works for everybody with cardiogenic shock.
Listen, don't break my heart. I hope,
Sorry.
you know,
You knew I was going to say
critical
it's
care and
complicated
nephrine is
once.
out there for me one day. Yeah, that'd be nice.
Working
That'd be
on
nice.
making it going to be millionaires any minute now. But I think like this is really, again, in the critical care literature, when evidence-based medicine can only take us so far because it's complicated. And I think people are starting to explicitly say this in the literature. This was a study that came out, or actually more of an editorial almost, that came out before this norepi study. And I just thought it was really prescient. And I'm just going to read it because I think it sort of gives us permission and a way to do thinking. The considerable interpatient differences regarding the initial cause of cardiogenic shock and subsequent consequences on both macro and micro circulation argue for a dynamic, step-by-step, and personalized therapeutic strategy. Vasoconstrictors should be used only after a reasoning process, a review of other possible options, and then should be titrated to reach a reasonable pressure target while checking cardiac output and organ perfusion. Basically, that's a long way of saying, do thinking. Your patient is complicated. You have to think about them in an appropriately complicated way. There's not a shortcut that you can be like, norepi is the one, use that. Sometimes it's the right answer, but sometimes it's not. And after this study came out, there was another really great just like review, basically being like, the current literature doesn't tell us the answer, so pick one based on your ability to be a doctor and do thinking, which is kind of my take on things.
Yeah.
Do thinking.
I can't believe this is what you agree with. Oh my God,
Straight,
what
it's
a
complicated,
surprise.
so do thinking. Yeah, that's the one. That's my take home.
But okay, so if you're telling me I can't just start people on norepinephrine indefinitely, potentially that leads to bad outcomes, who would have thought? And I have to do some thinking. We need a little bit of a framework here. I'm assuming I'm going to have to know a little bit more about each of these agents, things that are on the palette. I'm not just going to like throw dopamine at everybody, I guess. We have
Don't
to
do that either.
Yeah.
That's not the answer.
So what kind of framework do you suggest? Like how, when you see one of these patients, whether it's in the ED or the ICU, how do you go ahead and pick your vasoactive agent, whether you're looking for some inotropy, some vasoconstriction? What are those variables for you?
Because I totally agree that we can't just be like, well, I don't know, the evidence doesn't give us an answer, so eeny, meeny, miny, mo method, like what do we do? I think this is when really it becomes important to have an organized clinical problem-solving approach that takes into account best available evidence, but also everything you know about physiology and medicine and reassessment of the patient. Now, before you get into this with any kind of vasoactives, you have to have a framework, a mental model, so to speak.
I feel a chart coming up.
About, you do, there's a chart.
Okay, here it comes, here it comes. I
Ready,
love it.
and bam, a chart. You need to have a chart. No, you need to have, we're going to call it a mental model. That sounds so much better than
It
a
does.
chart,
That
right?
sounds
I think, okay,
way
yeah.
better.
But you need to have a way of thinking about vasoactives that's not the chart you've memorized as a med student, because that you probably memorized and forgot, I memorized and forgot, and doesn't help you at the bedside. So this is my mental model for thinking about vasoactives that'll allow me to help apply it at the bedside. I put them into three categories. You have your pure vasoconstrictors, you have your inotropy plus vasoconstriction, and then you have your third category, which is your inotropy plus vasodilators. In terms of the things that fall into those categories, our pure vasoconstrictors, that's our phenylephrine, vasopressin, and most recently angiotensin, which we're probably not using much
I
yet.
got those bougie pressures. All
Yes,
right,
exactly.
yeah,
The
yeah.
fancy, expensive, bougie ones
Yeah.
that like most of us don't have, which is fine. But for completeness. Then you have your pressors that give you inotropy and vasoconstriction. And that is your norepinephrine, your epinephrine, and here is where your dopamine shows up. Then you have your last category where you get inotropy but vasodilation. And that's dobutamine, milrinone, and the other new bougie fancy one, which is levosimendan, which none of us are using, but again, for completeness. Now, this is the next part of the chart that I think is why nobody remembers it, because usually the next thing these charts do is they include every single property known to man on every single one of these pressors, and then you promptly forget them. Instead, I'm just going to include the ones that matter to me most clinically when I'm making a decision. And there's two things. The first one is arrhythmogenicity. Because as we saw, what that DeBacker study, that first study of dopamine plus norepi was probably telling us wasn't necessarily that norepi was good. It probably told us that dopamine was bad.
Turns
in
out
fact.
putting people in the VTAC, not great.
No, not
Yeah,
good for
not
them.
great.
Very unhealthy, particularly if you're already in cardiogenic shock. And so arrhythmogenicity is a key variable you need to think about for your pressors. Now, for your pure vasoconstrictors, they're great. They don't cause arrhythmogenicity. Fantastic. In terms of your that give you inotropy and vasoconstriction, norepi can be a little arrhythmogenic, but it's relatively neutral. You got to be on a decent amount of norepi before you start getting too arrhythmogenic. Epi is worse. Epi gives you a lot more arrhythmogenicity than norepi does, and dopamine is the absolute worst. Dopamine, very sad, angry face, extremely arrhythmogenic. Now, What about your inotrope vasodilators? For those guys, dobutamine is arrhythmogenic. It's not as bad as dopamine, but it's not fantastic. Milrinone and levosimendan, less so. These guys are a lot less arrhythmogenic. So that's your first variable. Your second variable is what they do to your pulmonary circulation. So I can't help myself. I'm going back to the right ventricle because I just can't not. But what do they do in terms of your pulmonary vascular resistance? Because, if you vasoconstrict the systemic circulation, that's great. Does it also vasoconstrict the pulmonary circulation? Because if you have RV failure, you don't want to do that. So what do they do? That's the second variable that matters. As far as that goes, in terms of your vasoconstrictors, phenylephrine and angiotensin increase vasoconstriction in the pulmonary circulation. Vasopressin, on the other hand, not so much. Norepi does somewhat, but not as much as phenylephrine. Epi less so, because the nice thing about epi, it has that beta 2 to balance out that alpha 1. So epi is better for your pulmonary circulation than norepi. And dopamine, again, gets a frowny, angry face, which is not so good. For dopamine, it does not do good things to your pulmonary circulation. We can now see why everybody hates dopamine. In terms of your inotrope vasodilators, these are usually good for the pulmonary circulation. Dobutamine vasodilates, and both milrinone and levosimendan are wonderful things for your pulmonary circulation. So this is the framework that I use when I'm thinking about pressors. This is my mental model, and then from there, I can then go down my approach to vasoactive selection. And this right here is really what I mean by saying, if we don't have good evidence, we shouldn't just throw up our hands and be like, hopefully I'm feeling smart today. We should instead have an organized clinical problem-solving approach. And this briefly is my organized clinical problem-solving approach to vasoactive selection. Step 1, what is my patient's underlying shock physiology? Now, part of that is, are they in septic shock? Are they in cardiogenic shock? But even within cardiogenic shock, am I talking about LV systolic dysfunction, diastolic dysfunction, RV failure? What kind of cardiogenic shock am I really talking about here? What do I think is the underlying physiology really driving this? Once I have that straight, or at least I have a hypothesis about that, then I ask myself, all right, how can I use a vasoactive to modify that physiology to improve tissue perfusion? What do I want to do here? Do I think they need systemic vasoconstriction? Do I think that this is a patient who actually is getting really SIRSy, systemic inflammatory response from their cardiogenic shock, and vasodilating? Do I think this is a patient actually who's that classic cold, wet cardiogenic shock patient? They would actually benefit from vasodilation. Do I think they need inotropy? Or do I think this is RV failure and they need some pulmonary vasodilation? So that's the first question. What agents, how am I going to try and modify my physiology? But all drugs, including vasoactives, have side effects. So the next question is, okay, in this particular patient, what side effects am I most concerned about? Am I concerned about tachydysrhythmias? Is this somebody who has a history of AFib? Or somebody who I'm just watching the monitor and they're just throwing ectopy everywhere and I'm like, they're at high risk of going into tachydysrhythmias. That's bad, I shouldn't do that. Am I worried about systemic vasoplegia? Do I think this patient may have mixed cardiogenic septic shock? Do I think there's one of those patients that actually has a vasodilatory response to cardiogenic shock? Then, what about their pulmonary pressures? Do I think this patient has good RV, solid RV, I'm not that worried about it, or am I like, no, we gotta be careful? And finally, am I worried about mesenteric vasoconstriction for some reason in this patient? Once I've worked through, 1, how do I modify this physiology to improve tissue perfusion? And 2, in this particular patient, what are my biggest concerns? Then I say to myself, okay, I'm gonna go back to my pressor chart in my head. What agent or even combination of agents can I put together to give myself a cocktail that'll give me the effects that I want without the effects that I don't want?
That's perfect. And this is obviously, like, this entire thought process is not something this person hits the door hypotensive, looking like they're going to die, that you're going through. We're doing immediate life stabilizing things first, like okay to just start norepinephrine in that hypotensive patient and buy us some time to maybe do that bedside ultrasound, get a little bit more history and think about these things at a little bit of a higher level to figure out what physiology I need to modify, what side effects I'm hoping to nullify, and to create that ideal
100%.
personalized vasoactive agent selection.
And I think that's a great use of norepinephrine is that it buys you time. You know, if you start fluid bolusing people, it turns out you can't wring them out and get the fluid back. But the nice thing about norepinephrine, you can start it peripherally, you can stop it. It buys you time to figure out what's going on. It buys you time to do thinking.
Easy on, easy off. Well, thank you. I'm sure we have like a bunch of questions in the chat. If not, also you can post them on Slido and we'll follow up some more. That was a huge expert knowledge bomb that you just dropped. I'm gonna have to digest that chart probably for the next 3 years of my practice. but hopefully it'll be a lot more helpful when I see the next patient in cardiogenic shock, if I can recognize it appropriately. I guess that's a whole other can of worms that we won't get,
yes, we won't get into that. We don't have that.
Up next, we're going to put some of that critical care mindset into a case. We're going to do our board certified segment. So a reminder, we'll put up the slide for Slido at the beginning of it. We'll have a little bit of like a prep your mind survey going on before that will tie into our discussion of the care. Thanks, Sarah. That was awesome. All right, you guys ready for a rapid fire board certified case?
Rapid fire. I want to do a compendium pitch on the vasoactive chapter. Okay?
Yes.
So if I forget, I won't forget, but I want to make sure we throw that in.
Yeah, definitely.
Because it's been published for a while, like only not too long ago.
Yeah.
And Crystal Lives. And
great description of all of the different agents that are in there, and it's like a super helpful resource.
And if you're okay, we'll put your table in there too.
Go nuts.
Yeah, thank you.
Boom. Look at that, Corpendium authorship on air.
There you go.
Amazing. Are you guys ready to jump into a case? We got the Slido up if you guys want to join along with some quiz questions from home, but let's jump into it. So you guys are working in a single coverage, of course, ABEM general type emergency department. You have a patient who comes in, he's about 55 years old. He's actually a super utilizer of your department, has a known history of COPD, just brought in by EMS, super struggling to breathe. This person to you looks like the textbook picture of somebody who has emphysema, totally like pink puffer. You know them, you've treated them for COPD exacerbations probably like 100 times before in your 5-year stint at this hospital. This time it seems like the exacerbation was probably related to some smoking they had done earlier in the day, lost some meds. It's been a little bit of time. They're super working to breathe in the room, unable to speak, pursed lip breathing. What are some of the things you immediately are doing for this patient?
Getting a set of vitals.
Sure. Super tacky, like the 130s, O2 sats like at 85%. Normotensive, maybe a little hypertensive when you readjust the cuff, and respiring at like 35 a minute, just really like shallow, rapid breathing.
They came by medics?
Yeah, they came by EMS.
And they're giving me some additional history. What did they do en route? That kind of stuff.
Yeah, they started like one duo-neb treatment. You can see there's still some percolating in there. They said we literally, picked this guy up from around the block, presumably after a recent discharge or something. We haven't really got much more than that. Everybody knows Bill. He didn't really get much history from them.
Any associated features, chest pain, pressure, anything like that he's got?
Patient really can't tell you much more. They're really struggling to breathe, and normally you have like kind of a laughing, fun, jovial relationship with this patient. They just look a lot sicker than they normally look.
I'm immediately calling for BiPAP, ultrasound,
Right.
EKG. Yeah. Because really what I need to do in the first 5 minutes is, one, make sure I'm treating what I think I'm treating. I want to make sure this patient didn't just have a massive STEMI, and I want to get my ultrasound and make sure that all wheezing is not asthma or COPD. I want to make sure that I'm going to go down the route of treating COPD, I'm not missing anything, and then I'm going to call for my BiPAP. Because if this is COPD, then that is going to be the thing that's going to hopefully save me an intubation in this patient. And so calling for that, and hopefully my RT is getting me some albuterol as well.
Totally. So, the patient is super, looks anxious appearing, a little bit combative, fighting the BiPAP mask. You're having a hard time getting IV access. It kind of feels like a disaster in the room, honestly. The nurses are really frazzled. They're really struggling to breathe. You got chest x-ray nearby, EKGs lined up. You do a quick bedside ultrasound, and heart looks fine. You don't see any B lines, but it's also really hard to get a view. This person's wiling out in bed.
I'd ketamine him,
Yeah.
to be honest with you.
Okay.
I mean, it's great. It's not going to lose his respiratory drive. It'll kind of, mellow him enough to be able to tolerate the BiPAP, because the whole goal is to save yourself an intubation if possible, and BiPAP does that best. But a little bit of the anxiolysis, I think, from the ketamine.
Yeah, I mean, clearly when you have an agitated patient in this state, it's hypoxia, right? This is hypoxia when they are that agitated, pulling everything off, right? CO2 retention, they just get nice and sleepy, right? It's nature's paralytic. So you have to presume, if you can't get this person on the monitor, that they are hypoxic and you need to do something. And I think ketamine might be really, unless you're proceeding to intubation, but that might at least let you pre-oxygenate, get them as teed up as you can before you might be heading to ultimate. It sounds like this guy might be heading to intubation.
Okay, so kind of using the ketamine as like a procedural sedation for your BiPAP intervention.
Come on,
all your
ketamine.
other stuff, like really fingers crossed there. Okay, great. So do you want to give it, trying to get a line, you can maybe give it IV, IM.
Just
if
give
you
it
can.
IM. I mean, if the whole problem is we can't get control of the situation to even get an IV, just give it IM, control the situation. Now we can get an IV. And also once I find often patients who are really combative with BiPAP at first, because if you think about it, if you can't breathe and somebody tries to smother you with a big mask, you're not going to love it, strangely enough. But if you can get it on there and get them synchronous with it, they often feel so much better that they'll then leave it on. And sometimes the other thing I do is they often don't need super high things. Like if we put them on like 20/10, that's a lot of pressure. And often for COPD, they may not even need the full BiPAP. Maybe they just need CPAP. So rather than starting with these high pressures, if I'm having somebody who's combated, not tolerating, start with a CPAP of 8, then look at their tidal volumes and see, do they even need that IPAP? Because sometimes that'll get you through.
Yeah, I think this is all hands on deck kind of thing. You might need to call for extra hands. I would give intramuscular if I had to, but I really want a line on this guy because you seem sometimes you give the intramuscular and everybody kind of says, okay, let's wait and see what happens. You might be waiting. If they are hypotensive, they are not going to absorb it well, right? So I would really try to get a line on this guy because I agree with Sara. Once his hypoxia starts improving, he's probably going to settle down. When he starts getting a little bit semi-conscious, he might lose some of that sympathetic drive that's keeping him alive too. So it's always a little bit of a delicate balance to kind of hit them hard with like a 5 milligram per kilo dose of ketamine. IM, that might just back you into a corner that you might not exactly want to be in.
Sure. Well, you can't get a line, so unfortunately you do have to give the
There we
slug.
go,
That's,
yeah.
that's your only choice in this case. And basically, instantly the patient starts relaxing over like 2 or 3 minutes. RT does the magical like nursing the BiPAP mask on, get some nice settings going. And then the patient just becomes very, very somnolent and is still doing okay in the monitor, looks okay in terms of like tidal volumes, all that good stuff for the BiPAP settings. Heart rate comes down, it's like now in the 90s. O2 sat, which you finally have now, is like 94, 95%, not hypoxic, and you get some labs. So the first thing you get is a VBG. And so this is a VBG result that you get from the patient while they're setting up X-ray. So this is on like a minute and 10 seconds of BiPAP. So what do you see obviously jumping out from you there?
His PCO2, of course. I mean, he's hypercarbic, and just clinically, again, right? I mean, maybe it was his O's improving, but it really is, for me, hypercarbia. You can clearly see that. I mean, I'll defer to our critical care expert, but I mean, he's very acidemic there, and this is a respiratory acidosis, right? And his heart rate's going down. I'm worried it's going to keep going down and become a bradycardic respiratory arrest if we don't get even more of a handle on things.
Sure. Is there any changes or things you'd want to do with this information? You just started BiPAP. You want to stay the course for a bit?
I would say the course. I mean, like looking at this gas, I don't know what his baseline bicarb is, but this
That's right.
bicarb's 31, which suggests to me that this guy is a CO routiner to some extent at baseline. I'd estimate his baseline CO2 is probably, 60s or something. He's just gotten on, and we haven't even given him NEBs yet. Right. And so he's altered and somnolent because his CO2 is high. And so I would give him time. It's just, once you intubate these patients, it's such a nightmare that I would give him time. I might go up on the EPAP a little bit. I'd look at his tidal volumes. If he's getting adequate tidal volumes and his CO2 is still that high, I'd go up on the EPAP, because for the same reason they do that pursed lip breathing thing, they're trying to prevent in-expiratory airway collapse. You giving them that auto PEEP, that deliberately stenting the airway open at the end of expiration, can really help. And then putting the NEBs through the mask can also really help you, because if they weren't moving enough air en route with EMF to get the NEBs to where they need to go anyways.
Sure.
So I would stay the course. I don't see a reason to emergently intubate this patient. I would get some Pressors ready to go, because he may get kind of unstable while we're doing this, but if this is a situation, I can use a little Levophed, little norepi to temporize while I'm optimizing him with my BiPAP, with my NEBs. I think I still have a window that I can work with him.
Angiotensin too,
This is the time for it. Actually, probably not the time for
Which
it.
Abumicon are we putting in our heads right now?
Okay, perfect. Yeah. Okay, and so you got the inline NEBs going, so you've got your albuterols, rocking and rolling, all that stuff. You got some mag, somebody hung for you. It's going for a little bit, hoping to do everything that you can. And you got some other labs back. You got a CBC and a BMP, and nothing too super crazy or surprising with these results here. You can see them on screen now. You expected, like you said, there to be some retention that was there. Who knows the chronicity of it? A little bit of a reactive leukocytosis maybe.
And now that we have him more mellow, I guess just stepping back and like looking at this guy physical exam wise, because you said he's a frequent flyer, you know him, you've seen his COPD exacerbation, and now he's here in severe distress. Is there anything else about his exam that's amiss?
Nothing else, like clearly much worse than you've ever seen him before. And like even on previous like ICU admissions, it just seems like maybe this exacerbation lasted a little bit too long compared to baseline. There was another like triggering factor, but there's nothing on your exam or anything else that suggests that this is different than a COPD exacerbation. You know, as there's a little bit more air movement in the lungs, you're able to actually like hear some breath sounds. Not, you know, at this point you use your ultrasound to take a look, and now you're actually listening. You know, it seemed to be responding to what you're hoping it would respond to, and you don't see any obvious like weird infection or like a bag of extra medication or something else going on. You feel like you're just really worried that this person waited too long and you're past the point of no return.
And we got the EKG.
Yep. So we
and
got
the
some
chest X-ray and all that stuff is
it's cooking right now. So you got this chest
Okay.
X-ray popping through. What do you guys think?
Looks like COPD lungs. I mean,
That's the
hyperinflated,
one.
flat diaphragm,
Yeah,
right?
not
I don't see any
mysterious.
infiltrates. Makes me feel more comfortable that this is just a really bad COPD exacerbation on this gentleman.
And your EKG came in, now that the patient's sleeping, heart rate's come down a bit, the tech shoots this over to you. You know, I know it could be a little bit hard to see from where you guys are saying no ST segment elevation.
It
looks like
pretty
sinus rhythm.
unremarkable, yeah.
Looks pretty amazing. So how long are you guys waiting to see a response to this therapy? Like, are you reordering a VBG? Are you looking clinically as a combination of those two things? How are you figuring out what the next step is for their care?
I mean, clinically, like,
Yeah.
you know, you've got him on for, 30 or 40 minutes. Is he perking back up? Is he able to talk to you now? Like, how's he doing?
It's been about 30 minutes, still super slumped over in the bed. Like, you know, intermittently nurses are like calling you, you're seeing like another patient, like, hey, like, we're gonna intubate this guy, you know, like he's just really like leaned over. You have to like rearrange him on the bed. You have him on one-to-one nursing since you've
I
sedated.
might correct my initial, because initially I'd say no, I wouldn't get another VBG. But if he's getting more and more somnolent,
Right.
I mean, I've taken I'm feeling a little bit more comfortable. At least I'm oxygenating him. I agree with Sarah. Look at even his serum bicarb. This guy's a retainer, right? I mean, look at his anion gap's basically non-existent, right? He's got a normal one. But if he's getting sleepier, that has me a little concerned. Again,
sure.
I'll
I'm
defer
a
to our
little
critical care
worried.
expert, but that makes
Yeah.
me worried, and I'm looking to maximize him, thinking that I might be heading towards intubation if I had to.
I would probably adjust the BiPAP at this point. I would go look at my machine. Is he getting adequate tidal volumes? If he is getting adequate tidal volumes, but he's still super sleepy, I would keep going up on my EPAP. Because sometimes their airways are just so floppy, they actually need a lot to stent it open. I would do another round of nebs, and I'd give a lot of nebs at this point. I just like go nuts with the nebs. And really at this point, I'm just trying to think to myself, am I sure that he's altered because of the CO2?
That's absolutely
Is this,
right.
or is this a true unrelated, that his CO2 is high, but actually that has nothing to do with it?
Yeah,
Exactly,
yeah.
and actually
Right.
he has a brain bleed, just kidding.
Totally.
And so that's really actually where I'm going down. And now actually my decision is, if this is COPD, I still think I have some time to temporize here. I can adjust the BiPAP, I can give more nebs, but I'm like, you know, if I get another gas, especially if the CO2 is better and he's still altered, now I'm intubating to go scan him, because now I'm like, I can't attribute this to the high CO2 anymore. So that's really sort of where I'm trying to head
That's a
diagnostically.
really great point. Yeah, and it's sometimes really unfortunate where you see the, you know, hypercapnia correcting. Maybe the improvement is not as much as you'd hope, but just to facilitate care, you might be forced to play the intubation card, which is
Yeah.
that's a great point, because this person's clearly too unstable to go to scanner unless you're going to
Yeah,
like
you can't send it to
hug
scanner
them
like
in the
this.
scanner and take it with you. And,
Fun that would be, let's not.
Yeah,
Yeah, no.
that'd be horrible. So you get another VBG. RT's like, hey, we got another one for you, and they brought you the first one for comparison. So now this is like about 30 minutes or so on the adjusted settings as you've been up titrating. Notice the CO2 is a little bit better.
This is a VBG?
This is a VBG.
Very impressive O2 on a VBG.
Yeah.
But maybe not in a good way. Like that could
Right.
actually be hurting us.
Yes.
High O2 in COPDers, it actually can mess up their VQ matching and make the CO2 worse. So the next thing I would do is actually come way down on the
Yeah.
FiO2, because that's probably not helping us any.
Yeah, it definitely
Especially
doesn't
if
help the
that's-
respiratory drive, right?
No.
The hyperoxia.
For sure. So you can down titrate the FiO2. You go back in the room, and now like the patient's like, nurse is like maybe retching a little bit,
forget
maybe has hypersalivation, maybe threw up a little bit. It's
Yeah,
like a
forget
little
it.
unclear.
Fine.
Okay, we're
Nerd.
intubating the patient. Patient gets intubated.
Towards intubations. Is there anything you'd set up differently to intubate this patient? Like obviously, they're acidotic. There's a lot of reasons why this is a high-risk intubation. But anything that's different for you?
I mean, I think just the preparation is going to be different, right? For COPD, or especially, right, that sick, and you know you're about to take his airway, you're only maybe going to get one look before this guy desats very quickly. So having all of your adjuncts at the bedside, I think, is key, and having the pressors, if you didn't already have them, having those at the ready too, because again, like he's more relaxed now, but still somewhat relying on
definitely.
sympathetics, and now we're about to completely take it all from him. So you imagine he's probably immediately going to become hypotensive and like pericode type intubation.
And I'd be willing to bag this patient because, you know, this is a respiratory acidosis, and the nice thing about that, as opposed to a metabolic acidosis, when you're intubating, you can fix that by bagging. So unless you're really worried about him vomiting, in which case forget it, but you know, if you make 7 attempts on this guy, even if his O2 sat doesn't go down, his CO2 is already 1 million.
Yeah,
it's going to become 100 million, and now you're really in trouble. So I would be willing to sort of take a look, you know, RSIM, take a look, but bag this patient between attempts if you need to.
Sure. And is this something that you're doing VL, DL, awake fiber optic? You have a scalpel right there.
I think it all depends on the actual person who's doing it, right? I mean, if we want to do evidence-based medicine, video laryngoscopy is going to probably be your best. I would have lots of rescue stuff, including an LMA. If I had an intubating LMA, I agree with Sara, bagging in between. I don't know if this guy's got a big belly that I have to worry if I lay him flat that's going to be pushing on there. So that's just going to be other considerations. But for me, I would probably do video laryngoscopy. I'd have a couple of tubes lined up, and then I'd have all my rescue stuff ready. So I'd probably start with the 7.5 with like a 7.0, like loaded, ready to go. If for whatever reason I hit some resistance, so I'm going to swap real quick with bagging him in between.
Sure. You know, some people for these severely acidotic patients, so like maybe like an AMPA bicarb before we tube.
That will help you not at all.
Not at all.
That'll help you not at all.
Pee it in the wind.
Yeah, that helps you not at all. Why? The only reason bicarb's going to help your acidosis is because it gets converted into CO2. Oh wait, this guy's just proven he can't blow the CO2 off. And so this, I actually am all for like thoughtful use of bicarb. I use it all the time, but not for this. This will just make your whole life worse. You're just going to make your respiratory acidosis worse is what you're going to do. So I wouldn't do bicarb. I would try to get a decent sized tube in there, because the minute you intubate this guy, your problem is going to be expiratory time.
Right.
And if you have a 7.0 in there, you're not helping yourself at all. If you can get a 7.5, if you can get an 8.0, fantastic. But like, I might do VL just so I can be feeling good about getting a larger tube in there. But honestly, whatever you're fastest at. It's just that if you end up with a 7.0, you're not helping your vent settings at all.
We don't often think about upsizing, like looking at a glottis, be like, oh, this can handle an 8.5. You know, like that's just not a thought that I normally have.
8.5 is like horse tubes we don't need, but like, you know, bigger tubes in this case are
comparing on the other end too, like having the smaller
the
tube
physics
for the,
of laminar flow, right?
Exactly.
Absolutely. That being said, I don't have a lot of time, so I agree with you. I mean, in an
Whatever's
ideal world,
fastest.
I'd go an 8.0 in this guy. It's just like he's got me worried that I might say, hey, maybe I'd go a tube lower, knowing that 7.0 is maybe hurting him, and hoping once he stabilizes and up in the unit, someone's going to swap that out and put an 8.0 or
you
something
do that if
in
you
there.
Need to. But a 7.5 is reasonable to start. Just be like thoughtful, because normally I don't care if I have a 7.0, but in this patient I do.
Sure. And then immediately post-tube vent settings, and we could talk for like literally a billion hours about vent settings in the respiratory acidosis. That's an obstructive physiology from a pulmonary perspective.
Yeah.
What are your main markers? Like if you had like a few things to remember in this critical situation, what are you thinking about?
The temptation is going to be put him on a fast respiratory rate because the CO2 is high. That's the exact wrong thing to do. The key thing is this guy needs enough time to exhale. And so that is a slow respiratory rate, and maybe start at 14, long IDE. So set that I time, your inspiratory time nice and short, so an IDE of 1 to 3, maybe 1 to 4. And then you'll know, because you look at the vent and you see, do you see breath stacking on the vent? I also, in COPDers, I'll often start with a PEEP of 8 sometimes, especially if that maybe helped us a little bit in BiPAP, just to stent those airways open. And then, tidal volume of 7 cc's per kilo, 8 cc's per kilo, somewhere in there is probably good. But the key thing is, keep in mind, intubating this guy, you have helped nothing. You have made his respiratory status worse, so you can't intubate him and think you fixed something. you need to keep going with the nebs, because people do this all the time. They intubate the patient, they're like, yay, high five,
We're
call
done.
it a day, we're done, leave the bedside, and then forget to start the nebs through the tube. So do not forget to do that. So slow respiratory rate, long IDE, lots of nebs through the tube, go nuts with the albuterol, and then maybe a little in a COPDer as opposed to an asthmatic, maybe a little extra PEEP, plus minus.
Yeah, so I mean, you're the expert in this area. I mean, this is where I'm working with my RT, and I'm telling him I'd go to an IDE to 1 to 4. I mean, I
Yeah,
just say
why
that's
not?
exactly what I would do. And permissive hypercapnia, he's already hypercapnic. He lives hypercapnic, right? So I don't care about that. But I'm pulling my RT and saying, hey, I'll just tell you, like, my perspective is, but I need their expertise. And if you're fortunate to have a really good RT, and just say, hey, let's then get this guy, at least from us who work exclusively in the emergency department, he's got to go. Like, hey, you don't gotta go home, but you gotta leave, right? You gotta go upstairs. You gotta go upstairs, right? Because he really needs critical care, and so an intensivist who really can tailor his therapy.
Not one-to-one care.
Yeah. Well, this was based on a real case that I had on my last shift of residency. This is a picture of me immediately after this case. It's funny, so a friend of mine got these balloons, like, congratulations for finishing residency. This is like a sign out. I like to get well soon. You can see by my face how that case went. It was a really, really challenging case. This person had like every possible complication from being intubated. Like, they were much sicker in the actual situation. They popped 2 pneumos, like through the course of their care, like a really, really challenging from every physiologic perspective, anatomical airway perspective. Luckily, like, walked out of the hospital. They did great. And we still see them to this day, which is wonderful. We get to kind of reflect on our whole experience. But thought it would be good to just talk through the acidotic airway and some of those, like, really important points that you guys brought up. The upsizing the tube is pretty funny. I haven't thought about that before.
7 won't help.
Yeah. Wonderful. So I know hopefully the questions that we primed you guys for with that discussion, I know we try to address most of them throughout the discussion that we had about the case. I'm interested to see what you guys said about using bicarb and a few of the other things when we review this Slido. Hope you guys had some fun looking at those. Before we go, I know we've been running a little bit long tonight. We've got so much
there's
great
been
content
so much
in there.
good
I know.
stuff.
So many good morsels.
Can we at least go back to the mystery image?
Yes, the mystery image of the night.
All right. So Dr. Crager, if you wouldn't mind, let's take it on home. What are those?
So I think the main thing going wrong with this patient was negative pressure pulmonary edema. This was a big, strong guy, and putting it together, what I think probably happened is he was down and out from fentanyl, but he's still having respiratory drive, so he's taking these, trying to take at least, these deep breaths against a closed glottis. And we see this sometimes in seizures, we see it sometimes in OR disasters where can't intubate, somebody's trying to breathe against a closed glottis. It turns out bad negative pressure is horrible for the lungs. And what can happen is these guys can get super sick, crump and die, and just get profoundly hypoxemic. And that was one of the clues with this guy. The imaging clue was, if you look at it, you'll see that sort of peripheral clearing. Like, it looks awful, but not like aspiration. But if you look at the bases and just right outside, like, it actually looks weirdly clear in just those peripheral areas. And that's the key thing, this horrible bilateral badness. Your lungs look horrific, but this was the thing that the ED doc was like, something's weird about this chest x-ray. It's that peripheral clearing that you'll see with bad negative pressure pulmonary edema. And when you see that, if that's what's happening, these patients just crump quickly. They go from like breathing okay to trying to die within a very short amount of time. They get profoundly hypoxemic. They need intubation. But the good news is, if you can support them through it, they get better on their own. Like, this isn't going to be like a long-term death from COVID lung kind of thing. They get better. But that's the finding that I was like, oh, this is going to be bad. And they can get super, super sick. And this guy actually really just became profoundly hypoxemic to the point that we actually couldn't get him back, and he actually ended up coding and dying from hypoxemia. And that's why I actually think it was probably more that in the chest x-ray findings, negative pressure pulmonary edema, than simply the kind of pulmonary edema sometimes you'll see with a narcotic overdose.
Yeah, so we were talking, right, there's some history to this. So this is not specific to fentanyl. Any opioid can do this. In fact, Sir William Osler in 1880 described non-cardiogenic pulmonary edema following an opium poisoning. So you can see this, and in addition to the inspiration against a closed glottis, there's some other thinking that there's alveolar capillary vasodilatation from histamine release, other chemical mediators, and then you'll see this often described after naloxone. Right, someone gets it, and that's thought to be maybe the acute withdrawal causes a sympathetic drive that causes this. I think it's multifactorial, right? That all of this happens. I don't want anyone to be afraid to give naloxone because there's millions of doses given every day, and this is pretty rare to happen. So I think there might be a genetic predisposition, maybe a whole cascade of effects. As Sara said, this seems to be the negative inspiration on a closed glottis. But you can see this occasionally. It's scary when you happen. You don't see it that often, but when it happens, it can be pretty scary. And then you get that funky chest x-ray and like, what the heck is going on here? And I was actually quite surprised and sad to hear that this patient died.
Yeah, it's unfortunate. There is something like it's weird. I don't know why I feel it's like such a crazy thought to think like Sarim Osler at that time was like dealing with like opium overdose, like get the billows, like what were they doing back then? But yeah, that's crazy that it still holds true to this day.
Oh man, so there you go. We went with a little bit of a tough one today for the EM crowd, but some good information, things to think about in all of the images today. Who won?
Yeah, so we will find out who's the first person in the chat, and we'll get you that prize. I don't know if we have a name at this point, but we'll find out. We'll announce it, and we'll get you those AirPods. Don't worry, our people will call your people. Feel very reassured by that statement. But wanted to thank you guys all so much for being part of our Grand Rounds tonight. Our first one of 2023. Got it under our belt. It's exciting. We covered so many great topics. Everything from like dental trauma to pelvic exams to cardiogenic shock to Sir William Osler, and in one show. That's a pretty good range, I think.
I'm impressed.
Can I give a final shout out?
Yeah.
So thank you to everybody here and the great discussion on vasoactives. We have a vasoactive chapter called Introduction to Vasoactive Chapters in the Compendium textbook, written by Crystal Ives and co-author. She is an emergency physician and critical care specialist. If you are new or you just want a refresher on vasoactive meds, we're going to add in Sara's information that she put in there. So check it out in Compendium.
Absolutely. Thanks for that shout out. Again, don't forget the doobly-doo down below. Subscribe, hit the alert bell. We're going to come back at you next month. I believe it's February 7th. 7th? I got that right. I'm like terrible with calendars. So February 7th, we'll be with you with an urgent care Grand Rounds. And then also keep a lookout on the next few weeks. We're going to try to do like a little post-game of this Grand Rounds, add some more context, maybe some more literature in there. We'll post it on YouTube, and feel free to check it out on the MRAP HD page as well. Get all the links, all the great updates, timestamps, all the stuff you know and love if you want to reference any of this stuff later. Thank you guys so much. Thank you to the patients that made tonight possible, for all of you guys for listening and enjoying nerding out with us about the thing we love doing the most. Have a great night.